Hello, this is Desiree Chappell. It's Tuesday. Welcome to the Roundtable, where we have in-depth conversation with the experts as well as those on the front lines of perioperative care.
Top Med Talk.
Good morning and welcome to the third annual Interdisciplinary Conference on Orthopedic Value-Based Care. I'm Desiree Chappell, host of the Roundtable on Top Med Talk, and I'm here this morning. I had the privilege to sit down with Bill Prosser, who is one of the delegates here. He's a CRNA from Peace Health in Florence, Oregon. That's right. Well, Phil, thank you so much for sitting down with us.
Oh, thanks for having me.
Yeah. Have you enjoyed your time at the conference so far?
I have. This is one of the conferences that I really look forward to coming to each year. Yeah. There are a lot of national thought leaders and really innovative and thought-stimulating and provoking things that go on here. So, yes, I'm having a great time.
Good. Well, Bill, tell me a little bit about yourself. Where are you from? What type of practice that you've been in, and kind of what you guys are doing in your practice when it comes to value-based care?
Well, I originally grew up in a small town in Maine and left to go into the Army Nurse Corps back in the 80s and was inspired by the nurse anesthetist that I ran into there. Decided at that point it was something that I wanted to do. Took a almost 10-year detour between working in emergency medicine and neurosurgical ICU at UC Davis Medical Center in California, and then was in the first graduating class from Samuel Merritt University and became a CRNA. Went back to UC Davis and practiced there for almost another 20 years, and then decided that I really had a want or a need to take some of the things that I learned in that kind of an academic environment out to the rural United States. Fast forward, wound up in Florence, Oregon, and am working with a team of great people with fantastic administrative support to try and bring some of the very best practices in enhanced recovery and opioid reduction to a small town in Oregon.
Wow. So tell me the size of your group and what type of group that you're in.
So we have 5 nurse anesthetists in our group, and we serve a 21-bed hospital 24 hours a day, provide all in-house anesthesia-related services, airway management, acute pain consultation, and do a variety of peripheral nerve blocks and vascular access techniques for the hospital.
Wow, that's fascinating. So you are deep in the trenches out in rural America.
We are, and it's a small hospital, and when it's stormy in the winter, it's almost impossible to get to a bigger hospital, and so it can be very austere, and sometimes we can really feel like we're way out on the frontier.
I can't even imagine. I'm sure I work in an urban area, but I'm in Kentucky, so I can relate to some of the issues that you have. So tell me, Bill, you said that you guys are really focusing, and one of the things that you've tried to do is bring best practice to your group. What are some of the initiatives that you've brought in or that your group are really working on right now to improve patient care, kind of past the dogwood, kind of what we've already done? What are some of the innovative things you guys are doing?
Well, we started out, for example, Florence is primarily a retirement community, and our median patient age for surgery is somewhere around 71. So immediately it became apparent that the need for rapid and sustainable opioid reduction was going to be something that we needed to do. With the support of the hospital and the pharmacy, actually, we brought in some novel products. We're the first Peace Health hospital that has sustainably used liposomal bupivacaine, and we use it in our general surgery service lines, we use it in our orthopedic service lines, and with the combination of that and a standard 3-drug multimodal regimen, we've been able to reduce our hospital opioid use by 70 to 80% over just 2 years.
Wow, that's amazing. That's crazy. So what are some of the outcomes that you're seeing with your patients? I mean, patient-reported type of things. Are you guys collecting that, or?
Oh, we did initially when we were doing the med use evaluation for the liposomal bupivacaine, and we found that the percentage of our patients, particularly for like our inguinal hernias or our outpatient general surgery procedures, that those people were virtually opioid free. With our total joint program, where the patients tend to stay in-house, it's been a little bit longer piece in getting and eliciting buy-in from the nursing staff on the use of the multimodal regimen and intentional avoidance of opioids unless they're really required. Overall, in the community, we've been into this for about 2.5 years now, and I'm hearing more and more from the people in the community that they feel the pain control is a lot better and people are a lot less foggy, and they're getting back the relative who went in for surgery rather than somebody who seems like they're not quite right.
Yeah, it's interesting. We talk a lot about brain health on Top Med Talk. And, there's a lot of different explanations about post-op cognitive dysfunction and delirium. And we talk about neuroinflammation, opioids. So I think it's interesting to hear that, with just the pure reduction in opioids, that is contributing to, maybe keeping people a little bit more clear. And, is that something, do you guys actually do any risk stratification or assessment for cognitive function before surgery? Is that anything you guys routinely do?
It's something, where our anesthesia group is very small, and so we have a very tight communication loop, and so we all take our turn doing the preoperative evaluations, and it's something that we're cognizant of. We talk about the need for identifying people we feel like are at risk. As far as a standardized tool, I think that there are technologies that are coming in that direction that we would like to implement in the screening process, but I'm not really sure that they're there and scientifically validated just yet.
Yeah.
But if, for example, I had a patient who was substantially north of 85 years old in the last month, and felt like he was at extraordinarily high risk for postoperative cognitive issues, and did great. Communicated with the whole team. It's a little different than the formal channels of communication that you might see at a bigger hospital, where typically I can be sitting there in the office and text the orthopedic surgeon and say, "Hey, just saw so and so, and I've got some concerns, and so let's make sure we're really tight on this," and then we're able to execute that because it's a very small team.
Yeah. You said that you use multimodal, so you're using liposomal bupivacaine. You're doing a lot of regional anesthesia. Is that correct?
We do a fair amount of regional anesthesia, but what we discovered, and everybody on our team is actually pretty proficient in regional anesthesia, but one of the things that we found is because of the way our system bills, a lot of these things, especially a lot of the intra-abdominal things or the total joint procedures, that it's much, much cheaper for the patient in the end if the surgeon does an on-site infiltration. And because of that, we're able to knock, $1,500 or $2,000 off the patient's bill. And so far, we found that they're getting equal quality analgesia.
Interesting. Oh, wow. So a real collaborative effort with
it really
your
is.
surgeon colleagues.
And, early on in the rollout, as the literature builds on the liposomal bupivacaine thing, it's becoming really apparent that injection technique is critically important for results. And fortunately, with just a few surgeons, it's pretty easy to elicit buy-in from them.
Yeah.
And then as they see the results, then it's very easy to keep them on task with that.
Yeah.
Not that they necessarily listen to everything that we say, but
not that you necessarily listen to everything they say either.
That's correct.
We know how it all works, but it's good. It sounds like there's great communication there, and it does help whenever it's a smaller facility for sure. Now, I'm just going to ask this question. It's kind of simplistic, but and it's purely anecdotal and through your experience. But I know that multimodal pain management regimens usually include Celebrex, Tylenol, gabapentin, or COX-2.
Yes.
Gabapentin and Tylenol, or acetaminophen, and we're not being product specific here on Top Med Talk. But one of the things that I get asked a lot is, how do you modify those types of PO, oral meds for your different patient populations? Because a lot of people kind of push back on gabapentin now, and they're finding that because of, one, the addictive potential of that, even though we're giving 1 or 2, 3, 4 doses, but as well as the sedative potential of gabapentin. Are you guys seeing that? Do you reduce your doses? I'm kind of starting to ask everybody I meet now about
we
that.
do, and I can't cite you any robust statistical evidence, but basically what we've done is that we've cut it down to 300 milligrams TID for people who are under age 60. Okay. Between 60 and 75 or so, 200 milligrams TID.
Okay.
And then over 80, they get 100 milligrams TID. And that seems to be working pretty well, and the sedative effects that we're experiencing with that are pretty minimal. I know that in the initial, especially the total joint recommendations, the doses were much, much higher than that, and we were having a lot of problems with excessive sedation.
Yeah.
And we decided to start cutting it back. And I think it's still pretty efficacious at those doses.
Yeah, I've heard that as well. And that was actually my experience at our facility, Audubon Hospital, as we kind of started out with those higher doses and kind of started to pare back. So
the patients certainly didn't complain of pain on the higher doses.
No, they didn't. Weren't complaining about much of anything, actually, except that they were sleepy. That's phenomenal. Let me ask you about, it sounds like you guys are doing a lot intraoperatively and focusing on pain management. Are there other enhanced recovery principles that you guys are using, or perioperative or preoperative optimization?
Actually, we're building in more and more with that. One of my partners in the practice, I was lucky enough to meet in my doctoral program at Virginia Commonwealth, and she's come out to Oregon. Her husband was from Oregon, and a great steal from Georgetown.
No doubt.
She has started the entire American College of Surgeons ISCR program.
Yes.
The collaboration through Johns Hopkins, and she's running that program for all of our total joints now. We're a little slow because we don't have a ton of bandwidth to run all these things.
Yeah.
But we have the functional aspects of the colorectal arm of that in place as well. So we're doing pre-nutrition. We're encouraging patients to try and improve their METs prior to surgery. They're getting the multimodal. They're getting post-operative nutritional supplementation. And primarily we're using, one of the high-protein, relatively low glycemic index drinks and having them take that twice a day. We've chosen to use the ones that have additional iron because most of our patients are anemic pre-op, and we haven't really begun to survey whether we're getting any improvement in their hemoglobin starting 2 weeks out, but overall they're doing much better. We're having essentially for the total joint people what boils down to a preoperative boot camp sort of thing where they meet all the people that will be involved in their care team. They get their incentive spirometer so they can practice in a group. They get their nutritional drinks, their chlorhexidine wipes. They get additional instructions. In the future, we hope to do at least a trial with one of the cryoneurolysis devices as part of our prehab process. And in the perfect world, we'd love to give them a Fitbit then and some coaching so that they maybe can increase their METs by 15 or 20% prior to surgery.
Yeah. Wouldn't that be fantastic?
But that's something we're actively working on, and I'm hoping that when I get back to the hospital, I'll have some good news on the acquisition of those devices for that project.
Well, it sounds like you have great communication and great relationships with your administration that, hopefully that you've shown by utilizing some of these best practices, cost savings and things like that, and that it's beneficial to the patient. And so hopefully they're going to take a chance with you on that. Right?
Well, we've been able to reduce our hospital stay by more than a day in the last couple of years, which
for joints or
for joints. Well, actually for colorectal as well. I mean, typically our laparoscopic colectomies are going home somewhere around post-op day 2.2, somewhere in there, which I think is pretty good.
Yeah, that's fantastic.
And our surgeons are bought in with this, and we actually have a lot of support from the administration and the pharmacy on getting these things. And typically I hear that that's where some of the roadblocks occur.
It is, yeah.
And we've started to show them some value related to this and some improved patient outcomes and improved patient satisfaction, and so that's facilitating more buy-in from our C-suite and other ancillary departments in the hospital, like nutrition and pharmacy and physical therapy and all that sort of stuff.
So, Bill, we've talked a little bit about this, the difference in practice. You're from a small, rural facility. You have, you're not dealing with a lot of people. And I know that you attend a lot of conferences where, people are speaking to you from that academic setting. What do you think are some of the things that are easily, a little bit more easily attainable, and if someone's coming from more of a rural setting that they should focus on versus kind of the people coming from the academic perspective? Does that make sense?
Yeah. Well, I mean, you what I found is I get my best success out of discrete interventions that you perform, and then you don't have to worry about downstream things. Mm-hmm. This is why we've really tried to move away from indwelling catheters for either total joints or for epidurals if we can, because there's less possibility for error, less possibility for a mix-up, and we're trying also very hard to standardize our multimodal regimen across all of our surgical lines so that the ability for the nurses and people caring for those patients to predict what's going to happen next and to predict what the patient's needs are going to look like become more uniform. And so I think that increased standardization in a small setting and decluttering the patient care episode are probably the two big things that a small program can do, where in academics, you have all kinds of different teams and you have all kinds of people around. In a small hospital, you don't have that many people around, and so simplicity and applying known technologies that are proven are probably the best way to go.
Yeah, and it sounds like, you all have access to resources sometimes that people, and you would think in larger facilities would, but at least resources kind of get limited there. But I don't know. I feel like that is a conversation or a debate that we could have on and on, because you have plenty of places, small places, that say they're very resource limited. And I don't know. It's just interesting to think about.
I think a lot of that has to do with whether people are really willing to put skin in the game, stand up and champion the processes that they believe in, and really not take no for an answer, or at least not take a dismissive no for an answer, and just keep coming back. And in an academic setting, sometimes you're limited by the number of people that you have to convince that you should try a particular modality. And really in our place, I maybe need to convince 5 or 6 people.
Yeah, but when you're at UC Davis, it would be a different answer.
Well, I'm not going to brand them and say.
Well, not them. But I'm saying a larger institution.
Yeah. Well, if you're at a big institution, you may have to convince 100 people.
Right. Yeah.
And they may not necessarily want to hear what you have to say.
No, and we all know the bell curve of, the early adopters versus the ones the laggards that will never, want to change, and that change adoption models difficult with larger groups.
Institutional academia is a pretty comfortable ride, and so you have a few innovators on the edge, but I think the people that live in the bell curve there are definitely going along with the status quo.
Yeah.
So sometimes it's harder to change the way they think about some of this stuff.
Yeah. I think in the middle of that, too, then we have kind of your large, nonprofit facilities that are not academically affiliated, and those range from kind of where you are up until some pretty large groups, but they are not associated with academia, so it kind of changes things up a little bit, too. And that's what I'm interested in, is talking to people, just on the ground, and how do we get things done, and how do we take those academic principles and, utilize them, and how do we take your ideas from, small town, small groups, and put that into work too, and use that to help guide the way we do things in different sizes.
Yeah, the science is the same regardless of where you are. And you really have to make a decision whether you're going to trust the science and stand on it and advocate for it, or whether you're going to wait for somebody else to show you the way to do these things.
Yeah. No, absolutely. Well, Bill, I'm not going to take any more of your time this morning. I know the conference has started, so I want you to get in there and finish that. But I thank you so much for sitting down. I was really excited that we had the opportunity to do this, and hopefully we'll have an opportunity here in the near future. Do it again.
That'd be great. I look forward to it.
Yeah, well, and I know that you're an avid listener for Top Med Talk, so thank you so much.
I'm preaching Top Med Talk in the Pacific Northwest to anyone that'll listen.
Well, we appreciate it. You're going to have to push this one out to all your friends and family, right?
Well, I might want to listen to it first.
Oh, it's going to be great. It's going to be great. No, I love it. This is real life, and that's what we love, and that's what why I'm here is because I want to talk to people that are doing this. You know, nothing about the ivory tower. It's like, let's dig in, get in the trenches, and see what's happening on the ground.
Yeah, absolutely.
Yeah, cool. Bill, thank you so much.
Oh, thanks, Desiree.
All right, and thanks for listening to Top Med Talk here at the Value-Based Care Conference for Orthopedics, hosted by the American College of Perioperative Medicine. Cheers. Thanks for listening.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.